So I'll be talking about CX Detect and Monitor, some future trends and directions in bladder cancer diagnostics in terms of molecular markers. I'll just go into the presentation. So I am a consultant for Pacific Edge and was part of the trial design for the randomized study for the hematuria study, and there are the rest of my disclosures. These are my own slides. I have full control of my slides, so these are not pre-made slides. So economics of bladder cancer, you hear this all the time, but I'd like to start with this just to kind of give an idea of what we have out there. 7 million patients present with hematuria annually, 4 million cystoscopies in 2018, 81,000 patients diagnosed annually. 1 in 42 patients will be diagnosed with bladder cancer throughout their lifetime. Very expensive disease to treat. In fact, one of the most expensive in cancer care in general. So 2020 estimates $4.9 billion a year, an average lifetime cost of $220,000 per patient in the US. And I suspect this number is actually going to go up in the next 5 to 10 years because of all the novel treatments that are going to be coming up. And this doesn't even include the indirect costs and patient suffering, lost productivity, so on and so forth. So bladder cancer, again, very, very expensive. So why do we need urinary markers? Everybody uses cytology, cystoscopy. We miss CIS, we miss upper tract tumors. It is invasive. Some patients don't like it at all, as many of you can attest to. Cytology is very inconsistent. It misses 20 to 50% of high-grade disease, pretty much all low-grade disease. 10 to 15% are atypical, depending on where you are. Those are very frustrating for us, and it's not point of care. We have to wait for it, wait for the results. So we have significant limitations with use of cytology, and yet it's still part of our armamentarium. It is useful when it's positive, but when it's negative or atypical, not so helpful. So cytology, you need whole cells that have been sloughed off the tumor or caught in the voided urine. It is somewhat subjective. There's a high rate of atypical or suspicious findings. And again, depending on your cytopathologist, that rate can vary pretty significantly. Very low sensitivity in my mind for detection of bladder cancer. FISH is reflex to atypical cytology. It is quantitative, tells you the number of cells with aneuploidy, but again, the sensitivity is quite poor, highly variable, and I'm not so sure what to do with positive FISH because you chase your tail. These are chromosomal abnormalities, and you do, again, need whole cells to look at. So major limitations on our current sort of FDA approved diagnostics. We did do a study a number of years ago looking at positive Eurovision associated with recurrence rates following BCG treatment. And we did find like it had a 3.3-fold increased risk of recurrence if your immediate post treatment FISH was positive. So sensitivity was again poor in this prospective multi-institutional study, 36%, specificity 76%, with positive predictive value of only 40%, and a negative predictive value in the 70%. So it may be useful in stratifying patients entering into clinical trials, but really these numbers are just not good enough for us to use in daily clinical practice. I wanted to show you this other study real quick. This is the efficacy of safety of blue lights, a flexible blue light cystoscopy. This was a phase 3 comparative multi-center study. This was prospective, published a few years ago, that led to the approval of flex blue light in the US. But look at the cytology. I want you to see the patients who had lesions that were detected by blue light only and had CIS. There were 0 of 13 patients with positive cytology, none of them. So these patients are patients that we pick up with blue light only. So again, there are a few suspicious and atypical in there, but 6 of the 13 were completely negative. So we're missing CIS all the time, as we saw in this prospective trial and we've seen in the past. What are some other approved urinary biomarkers? You can see the list there. I don't think anybody that I know uses BTA and NMP22. Those were really old markers. I used to use them in the beginning of my practice. but very, very, again, poor sensitivity. That 100% is not seen in general practice. It's in the 40 to 60% range, with specificity, again, in the 70% range. Doesn't really help much. Now, I put this statement from the AUA guidelines. A clinician should not use biomarkers in place of cystoscopic evaluation. That was 2016 recommendations. Things are maybe beginning to change, and we have a lot more data right now. For the NCCN guidelines, there is a remark there that for urine tests, you do urine cytology as we all do, but consider urinary urothelial tumor markers with a category 2B recommendation. So we're getting more and more evidence to be able to put these markers into perspective and put it into the guidelines. So there is expanded use in low and intermediate risk categories as well. This was for high risk patients, this recommendation. But again, I think there are other situations we can do this in immediate risk patients as well. What about other urinary biomarkers? What's out there? I could do an entire lecture on just these biomarkers alone. Gene Expert, I just put sort of the list there. I won't go into details because I don't have much time, but Assure MDX, EpiCheck, Cxbladder, some of these are available in Europe and not here. Euromonitor, Bladder Care, which gives you a quantitative assay methylation. So there's lots of different sort of targets, and these are out there, some of which are in production, others are not so far along. But in any case, should we use markers for every patient? I think no. The answer is it's not necessary. It's not recommended by the AUA or EAU guidelines. I'm on the AUA guidelines panel. Again, we do have more and more data than we did in 2016. I always tell the residents, this reflex descending cytology. When you're looking at a tumor, don't be sending cytology. That's not going to help you. You're going to have pathology of the actual marker. So if you have an unclear lesion, in the operating room or in the flex, obviously you're going to send cytology, and if it's positive, you're going to pursue that further, looking at the upper tract or prostatic urethra in men. But those things are rare. The money is always in the bladder, most likely. So if I have typically I'm going for a blue light, looking for that CIS, as we saw in that prospective study. But atypical findings are still an unmet need, and we continue to work on that. So Cxbladder is a genomic test. It helps with detection and management of urothelial carcinoma. There are a number of different tests, even though the test is the same, the algorithm is different. So for hematuria, there's Triage and Detect. This is a hematuria evaluation, and Triage is optimized to rule out low-risk patients, and Detect is a detection test to help rule in or rule out urothelial carcinoma. For surveillance, which I do a lot of, I use Cxbladder Monitor. It's optimized to rule out low-risk patients and even high-risk patients, and I'll give you some more data on that. Adjudication of atypical cytology, it performs really well. Equivocal cystoscopy, we have a prospective study ongoing right now using Cxbladder with blue light, with flexible blue light, looking at these equivocal lesions that we don't know what to do with. Should we take the patient to the OR? We get atypical cytology, the patient has inflammation, and so on and so forth. And then lastly, there's in-home sampling now that allows for risk stratification to prioritize patients into high risk for immediate follow-up versus a little bit of deferred follow-up. And I'll show you some data there where in-home testing has become sort of really helpful for these patients. So gold standard remains cystoscopy. It does have performance gaps. There are false negatives and false positives with white light cystoscopy. The number of studies you can see there, the mean sensitivity for picking up tumors in the 70% range. And you say, well, how's that possible? How else are you going to detect this tumor? Well, blue light is one, and two is if you do a white light and you come back with positive cytology, and you go in and then find the tumor in the OR because of better optics or whatever have you. So absolutely, we miss things on white light. We miss things occasionally on blue light, but it's really been helpful to have all these in your armamentarium. So What are the biomarkers that Cxbladder uses? This is, again, for both hematuria evaluation and urothelial cancer surveillance. There are 4 biomarkers that are involved in varying aspects of growth. I won't go into the details of it, but these 4 biomarkers are unique. They're well known in cell proliferation associated with bladder cancer. And cancers of the urinary tract, there aren't that many studies or that many cases of upper tract tumors, but I suspect that actually performs quite well there as well. There is a 5th biomarker that's indicative of inflammation of bladder tissue, so that helps to decrease the false positives in patients. And all this gets put into an algorithm that's proprietary and comes out with this result. So this is a good way to look at it. This is Cxbladder has for surveillance, it has monitor, negative predictive value 96 to 97%, very high sensitivity 91 to 93%. These are numbers you had not seen before in the previous biomarker space. For hematuria, for rule in, you have detect, again, negative predictive value, very high 97%, and sensitivity of 82%. So the triage also is the same. So triage helps to rule out the low risk patients and helps to defer further workup. So there's lots of patients which we have very low suspicion that they have urothelial carcinoma, yet we're obliged to do the full workup of CT scans and cystoscopies. And this is a very, very helpful test to put them in that category of most likely negative, and tell the patient, look, there's a 98.5% chance you don't have bladder cancer. Of course, you do your workup for the other causes. But at least, if you already found a cause like a stone, you can rule out urothelial carcinoma in this patient. So where's the data? There's lots of data. Over the past decade, there have been a number of studies, a dozen studies actually on Cxbladder in major peer-reviewed publications. We've been part of some of these, but you can see the results there, where the sensitivity and specificity consistently and persistently, no matter what population you look at, come out in that 90% range that we're looking for. So whether you can see on the top 2 studies are for surveillance and the bottom 3 are for hematuria evaluation. And again, I'll go into some of the details, but the sensitivity for most of these are very, very high. So there are 2 additional newer publications, one from Conetti, Badri Conetti, Neil Shore et al. In European Urology for adjudication of atypical cytology. I'll go through that a little bit more detail. And then another publication recently with 570 patients looking at sensitivity and specificity is 96 to 98.6%. So it really outperforms all the other biomarkers currently in the market that I'm aware of. So clinical validity of detect and triage also has been shown in multiple studies. Again, I showed this partly in the other slide, but this is again for hematuria workup. There's lots of this in general urology practice and VA type situations, and where there's a lot of smokers in the VA population, as well as the county population, where you're overwhelmed with a number of cystoscopies that need to be done, and detect and triage can be very helpful in ruling out urothelial carcinoma. And you can do, again, your workup, whether it's a CT urogram or a renal ultrasound. And again, we have a randomized study right now that puts patients into 2 categories of who are low risk. If you're detect negative, then the patients just get an ultrasound and do not get a cystoscopy. And the ones who are detect positive go on to the standard treatment. So we're trying to see if we can safely omit cystoscopy for these patients, and that's an ongoing multi-institutional study. So that'll be sort of level 1 evidence that it's safe to omit cystoscopy in some low-risk patients who we don't suspect have urothelial carcinoma. So this was one of the best publications. This was in 2012, already 10 years old. This was to establish the performance characteristics of Cxbladder in detection of bladder cancer, and then compare it with cytology, NMP22, bladder check, and NMP22 ELISA. So one of the early studies to do these comparisons. Good number of patients, 485, all had hematuria. They all underwent cystoscopy and histopathology to rule out disease, and the median age, the usual, 69. There was sufficient performance in the initial stages of this study to show that it challenges urine cytology as a routine adjunct to cystoscopy. Great detection. You can see the overall sensitivity was 82% with a specificity of 85%, and you can see the rest across there with cytology, NMP22, and NMP22 ELISA. So there was a second cut point established that raised the specificity to about 94%. So there's been refinements to the algorithm and how this is done. And you'll see this throughout the presentation, how as we go on, that the algorithm is improved significantly. So this was a relatively recent study over the past few years. What do you do with those equivocal cystoscopies, the atypical cytologies? This was a look back at the studies that had already been done and looking at the patients who had atypical cytology. Cxbladder ruled out 35% of these patients who had urothelial carcinoma, who had a history of urothelial carcinoma with a negative predictive value of 97%. It missed 8.5% of the urothelial carcinomas, whereas cytology missed 63% of the tumors. So I do want to go into detail for this one. If you look at the Cxbladder negative patients, and the total number was 153. So Cxbladder negative patients, 47 of them had no tumor. None of them were positive when the Cxbladder said it was negative. So 100% adjudicated the cytology there. If the Cxbladder was positive, still 80 of the patients did not have urothelial carcinoma, but 26 did. So obviously, we don't want to miss any tumors. We're going to get false positives. So the most important thing, at least, in my mind, is making sure that we're not missing anything and cut out all the patients who are lower risk for this cancer. So based on this study, I use it quite often. That's exactly what I do for atypical cytologies. I have urine set aside, and we can talk during the QA about how, logistically we do that. But again, there was not a single patient who had urothelial carcinoma where the Cxbladder was negative. Very, very important distinction there. So it outperformed cytology, adjudicated all the atypical cytologies and atypical cytology with equivocal cystoscopies, and they were concordant for all the positive cases previously categorized as atypical. So 35% of the patients were able to avoid further cystoscopy and advanced diagnostics. So this is what the detect looks like. Cxbladder Detect normal gene expression. This is the report. You have the normal gene expression score, less than 0.12. You have the elevated between 0.12 and 0.23, where the negative predictive value is 94%. There's still a low probability of urothelial carcinoma. It might change how you further manage the patient. If your score is less than 0.12, the negative predictive value is 97%. So you can use that however you want to. When you have a high gene expression score, the positive predictive value is 68%. So I always tell the patients, look, a positive CX doesn't mean you have cancer like a positive cytology does. A positive CX just means we need to do further workup. And it doesn't matter where you fall in this. This is not a quantitative study. It doesn't matter exactly where you fall in. These are cutoffs. So if you're 0.24, it doesn't matter if it's 0.24 or 0.36 or 0.45. It's all in that positive range, and you need to do further workup to determine whether the patient has carcinoma or not. So moving on to surveillance of patients with bladder cancer. Again, we talked about monitor. We're monitoring the disease. We know that 70% of all bladder cancers are non-muscle invasive. Urothelial carcinoma obviously is the most recurrent of all cancers, leading to the high cost. Management surveillance is somewhat intense. We're watching these patients if they're high risk every 3 months in the first year or two, and every 6 months in year 3 or 4, and annually thereafter. So there's a lot of cystoscopy being done. We do imaging tests, CT scans, CT urograms. These are all from the guidelines. Again, going back to the studies, this is the clinical validity of Cxbladder Monitor in peer-reviewed publications. There was a JU publication 2017, sensitivity 93%, and very, very high negative predictive value of 97%. So the second study, Urologic Oncology 2017, 1,000 samples in 803 patients, and Cxbladder consistently outperformed all the other comparator covered tests that we'd seen in the previous studies. And again, we talked about the evaluation of and adjudication of the atypical cytology, where Cxbladder correctly adjudicated all the urothelial carcinoma patients. Sensitivity was 91.5, negative predictive value 97.4. So again, you see this consistent pattern here, and I love it when the data is consistent, because it tells you that it's real. No matter what population you look at, what study you look at, you end up with the same study. The sample sizes are large. The adjudication study was 2,000 samples from 1,700 patients. So these are not small studies. And these are, some of them are overlap, but most of them are unique studies. This is another study looking at performance characteristics of Cxbladder for monitoring recurrent urothelial carcinoma. This was a multi-center study, 763 patients, 1,036 samples. The patient had or were treated with for bladder cancer in the previous 2 years. Again, the overall sensitivity 93, and you get tired of me saying this, and negative predictive value of 97. But look at the stage breakdown here for the T1 tumors, for instance. I picked up 20 of 20, picked up every single one. For the CIS patients, it just missed one. So there were 29, and it picked up 28 of them. TA tumors, it didn't diagnose 11 of them. So the sensitivity increases as the stage increases. So you're looking at low grade and high grade. We have very, very poor sensitivity for cytology for low grade tumors, but here you have an 85% sensitivity for picking up low grade tumors as well, and 97% for high grade tumors. So these are very, very good numbers. And interestingly, as the age increases, your sensitivity also increases, because the chances of having bladder cancer as you are older increases. And again, you can see the negative predictive value there. This is the comparison with the other ones. Again, sensitivities 91, negative predictive value 96, and you can see that cytology was 22% in this study, 87% negative predictive value, and the other tests really are not used very often. I do see FISH used quite often, and look at the sensitivity is 33%, and this is my major issue with Eurovision, is that most of the time it's actually not cancer, and so we get referrals for evaluation of cysto negative, white light negative, cytology negative, and somebody sent a FISH and it was positive, and what do you do now? It's variable depending on the risk of the patient. I have the luxury of having blue light in the office, so we do flexible blue light. We may do that for FISH positive patients, but again, the sensitivity is quite low for picking something up. So looking at NCCN guidelines, again, this is July 2019. For surveillance, it does say that many of the tests have better sensitivity for detecting bladder cancer than urine cytology, and urothelial tumor markers may be considered during surveillance for high-risk non-muscle invasive bladder cancer. So we're kind of getting there. And again, there's better studies now. This was 2019, so all the studies were probably 2018 and before, and now we have more and more data. Here's a study looking at real-world use and clinical utility of Cxbladder Monitor. This was just recently published, and one of my partners, Ann Schuckman, is a co-author on this paper. This is looking at a surveillance protocol that incorporated Cxbladder Monitor at 3 large public healthcare providers. There were 443 tests performed on 309 patients. There were mostly low-risk patients, 52 high-risk patients, 52, which was almost 17% high-risk patients. So Cx Monitor ruled out 77.8% of patients who did not have a urothelial carcinoma. And at first cystoscopy and follow-up cystoscopy, equivocal cystoscopies, there were 13 confirmed urothelial carcinoma recurrence events that were identified among the 67 positive patients. So again, we're going to have false positives, but the fact that the positive leads you to doing further tests on these patients do end up with cancer is very significant. But most importantly, 35 months longitudinal evaluation, Cxbladder Monitor missed no high-grade tumors. That's pretty remarkable. So anyone who had a high-grade tumor, we've seen the sensitivity be up as high as 97, 98. And in this study, there were no missed high-grade tumors, and no patient progressed to muscle-invasive bladder cancer or metastasis. So this is really, really good data that's prospective. And one of my good colleagues and friends, Seema Important and Todd Morgan from University of Michigan, Max Meng, did this study looking at Cxbladder Monitor to reduce the frequency of cystoscopies. This was very recently published. So if you look at, this is during the COVID era, the bladder cancer patients, if you look on the left side here, they had scheduled cystoscopies March through June of 2020. This is exactly during that COVID era. There were 43 patients that were ineligible. Some declined the CX monitor. So there were 92 patients who were eligible for this study. They got a CX monitor score. If it was less than 3.5, which is in that negative range, they got to skip the cystoscopy, the surveillance cystoscopy. They didn't have to come in to the hospital. These were home kits sent to the patient. And then 24 were positive, and they went on to further cystoscopy. And again, you can see the 37.5% positive predictive value. The ones that were positive, there were 9 patients who ended up with urothelial carcinoma, and you can see the path stage there. The cytology was negative in most one of these patients, and was high grade in 67%. The ones who skipped immediate cystoscopy, that's the focus of this study. What happened to those patients? There's a median follow-up of about 4 months. Some patients were lost to follow-up, but at their next scheduled cystoscopy, which was 52 patients, there was no tumor seen. So at least in this small study and a short follow-up, it was safe to skip that one cystoscopy in between or whatever the next follow-up cystoscopy was. The median follow-up was 4 months, so some of them were 3 months and some of them were 6 months. But again, it didn't miss any tumors, which is obviously very, very important if you're going to skip a cystoscopy. So this is something you can offer patients a home kit to maybe skip one of the cystoscopies and have them come in at the next scheduled visit. So this is what they propose. If you're more than 6 months from primary diagnosis, more than 9 months from recurrent diagnosis, more than 3 weeks for prior urethral instrumentation, and more than 3 weeks from intravesical therapy, 6 weeks for BCG. If your CX at-home monitoring is negative, you can skip the scheduled cystoscopy and perhaps come in for the follow-up cystoscopy. If it's positive, obviously, then you move on to your standard scheduled cystoscopy. But by doing this, you can reduce the frequency of surveillance cystoscopies, especially for patients who travel far away and have difficulty in transportation or just not going to come in. At least you have some test there to help with them. And this is what Monitor looks like. It's very, very simple. Basically, there's a green dot here that appears if your score is less than 3.5, and it gives you a negative predictive value of 97%. If you're above that, there's a higher chance of having a urothelial carcinoma, and you do the standard testing. So surveillance pathway, that you do need to be more than 9 months from a confirmed diagnosis of urothelial carcinoma. There's equivocal results from surveillance workup. We talked about atypical urine cytology. And the equivocal cystoscopies, both white light and blue light. I'm realizing now that I've done blue light for quite some time, there are patients who have equivocal findings on either side. Occasionally, we have slightly fluorescent areas, not necessarily areas of inflammation either. that turn out to be equivocal. The patient's on anticoagulation, and I'm not sure I want to take the patient to the OR for biopsies or do a biopsy in the office, which is hard to control when they're on anticoagulation. CX, again, is a great adjudicator for those patients. Now you have to have the urine prior to the cystoscopy, which we do because the patient's void before we put in their CysView for their blue light cystoscopy. For low and intermediate risk patients, the considerations to replace some cystoscopies, patients several years out from a recurrence, perhaps, especially low-grade patients or intermediate risk where they have recurrent tumors and don't really want to come in for that 3-month, 6-month visit and just want to do annual, perhaps you can split it and do a Cxbladder monitor. Again, there has to be a discussion with the patient. It's not 100%, but it's that consistent 97%. And from my experience, I can tell you that most patients will go for it. When you tell them you have a molecular marker with a 97%, they think that's very high. And we've done studies and patient-reported outcome studies where patients very much would rather skip a cystoscopy and do a molecular test. It can be an annual adjunct to complement surveillance monitoring, and again, we can extend the duration of the follow-up for many patients. So elderly, nursing home patients, those with comorbidities. Now, I want to spend a little bit of time on these sort of other tests. This is the hematuria evaluation, the triage and detect. Again, sort of wanted to put it in this format. The triage is really to rule out low-risk patients, and you have this detection categories of low probability versus not low probability, and the sensitivity and negative predictive value 99%. So it's great again for that overwhelming population of these microhematuria patients that you really don't want to do further testing because you think, the chances of finding anything is very, very low. At least you have a test there that they can literally triage patients and put them into low risk categories. Detect. Again, the genomic markers are the same. It's the algorithm that's different. It's the calculation of how they come up with these thresholds that's different, but the actual test, the urinary biomarkers are exactly the same across the different ones. And detect, very similar. You're trying to detect positive patients, low versus elevated versus high risk. So it's a little bit more categories there, and you can use it in general practice for detection. So this is sort of the newest out there, the urine analysis of FGFR3, which is a hot sort of topic and target right now, and TERT gene mutations, which we've known about for a long time, does enhance the performance of Cxbladder tests, and I'll show you this, improves the patient risk stratification. So these are SNP biomarkers. I'm not going to go into detail about SNPs. You're all probably having lunch and don't want to hear the deep basic science of this, but these are Cxbladder Triage and Detect Plus. So looking at 2 SNPs for the TERT mutations and 4 SNPs for FGFR3 mutations. So these are 2 additional biomarkers, but 6 additional SNP biomarkers to see if we can improve on the already excellent performance characteristics of detect and triage. So this is CX Detect Plus. Again, binary output, patients with hematuria managed by standard care. So less than 0.23 would give you a low risk. You follow the patient at 6 months. If it's more than 0.23, they're high risk, and you evaluate them with cystoscopy. So that's how it would look. Now, this was developed using a US and a Singaporean database. You can see the numbers there, 396 and 622 for Singapore, and you ended up with 344 and 460. So 804 patients. That's again a large study. There were 98 ineligible for the various reasons you see there, and 64 unevaluable patients, but you still have a very large data set. There were 61 tumors that were confirmed, 21 low grade and 40 high grade with or without CIS. Just a comment, because this comes up, you see the 64 unevaluable patients occasionally that comes up, of how many, you send a test and it comes back unevaluable. It's either a QC failure from the RNA side or the DNA side, or there's incomplete data on some of these patients. So you do get some tests back where it's just a QC failure. You just don't have enough RNA available for evaluation, but that is always less than 10%. And you can see here the performance characteristics of Cxbladder Detect Plus. You can see the negative patients there. None of them had high impact tumors. These are the high risk tumors. 2 of them had low impact tumors. For the Detect Plus positive, there were 133 patients, and 19 of them had low impact and 40 of them high impact. So you see across the bottom there, the sensitivity, specificity, negative predictive value, positive predictive value. Again, look at the negative predictive value. We went from 97 to 98% in the previous test to now 99.7%. So we're missing 2 low impact tumors, missing 0 high grade, high impact tumors, what they called high impact, but essentially these are high risk patients. So really good numbers, and it actually has raised a positive predictive value as well to 44%. So if the test is positive, there's a good 40% chance you're gonna have something there. So these additional SNP biomarkers improves the performance that's already excellent. You can see the incremental increase in sensitivity and specificity for the Detect Plus and Triage Plus patients. Really significant. We thought this was as good as it gets, and it just got better. We just learned of this new determination and improvement in the performance characteristics. And again, this has been just recently published. So risk stratification is improved almost 6-fold compared to the current AUA guidelines. Detect Plus is pretty well suited for risk stratification of hematuria patients. And the white light negative Detect positive patients is an active area of research. Again, just my bias is blue light is very helpful in these patients, but we still have questions of what to do with those equivocal patients. And we're doing this prospective study to hopefully show that we don't miss any high-grade tumors when we have equivocal findings and a negative Cxbladder monitor. So there's a lot of value proposition for this testing. I think it can be used for patients with suspicion of urothelial carcinoma, for asymptomatic microhematuria to avoid these extensive evaluations of patients who really don't need it. You get and practice very, very tired. We teach all the students and residents, you must do a hematuria workup. It's in the guidelines. And yet, in practice, you're overwhelmed with a number of patients with microhematuria or low risk. And a single test like this can rule out with very, very high predictive value that there's no urothelial carcinoma. Again, I don't want to discourage the usual workup for other causes of hematuria, but certainly I do a lot of bladder cancer and urothelial carcinomas, and we want to, it's very helpful in that setting. One of the most useful things that's come recently is home testing. It streamlines prioritized scheduling, improves the OR cysto ratio, and one of the things that you can do once you get your cytology back, we used to say, oh, wow, the cytology came back atypical. We have to bring the patients back. Well, now I look at the history when I see it, I'm like, well, I'm kind of worried about this high-risk patients. It came back atypical. I did blue light, but it was negative. I want to make sure there's nothing going on. We'll call the patient, send him a home kit. And then we'll have a Cxbladder result for that patient as well, and it can help to decide whether that patient should come in for biopsies or prostatic urethral biopsies, upper tract studies, and so on and so forth. So it's very, very helpful there. And again, you can avoid cystoscopies in many situations. Some people say, well, you're trying to take away the bread and butter, but look, after 1,000 cystoscopies, you get pretty tired of doing all these negative cystoscopies, especially again in large these large population patients like the VA county, where you're doing negative workups over and over again. And then I think, talked a lot about the atypical cytology situation. For monitor, you can use it for obviously the surveillance patients. ideal for patients who have a significant travel burden. One of the other things I'm doing is after 5 years, between 5 and 10, when the patients had no recurrence, the chances of recurrence between 5 and 10 is extremely low. I do offer them either continued annual surveillance or a Cxbladder test that we can either send to home and do a telemed visit to tell them the result. I have a patient who's 90 years old, who's not had a recurrence in over 8-9 years. And we send him a home kit and we just do a telemed visit. It's really easy. Lots of these types of patients out there. So I'll conclude there, leave some time for questions, hopefully, and some discussion. I think it does provide actionable information for both hematuria and monitoring patients with non-muscle invasive bladder cancer. We still don't have great data for upper tract tumors, but hopefully that's coming soon as well. There's a lot of activity and research in this area. And you have the Detect and Monitor test now with, in a summary of what they are, the same 5 genes, a negative predictive value, 97%. So with that, I think I'll stop and see if there are any questions. Thank you for your attention.